officer at The Dorm, which is both an IOP and PHP treatment community for young adults, roughly between the ages of 18 and 30. We do have locations in both New York City and Washington, D.C. At The Dorm, we very, very often work with clients who are struggling with both loneliness and isolation and the resulting symptoms such as anxiety, depression, substance use, and self-harm. They are not alone. Last year, the US Surgeon General and the World Health Organization both issued warnings about the epidemic of loneliness and declared it a global public health concern. This is part of the reason that our model is so centered around community and helping clients to locate a supportive network to help them sustain long-term recovery and to find just general meaning and purpose in life. And as we reflect upon how our community works with this ongoing loneliness epidemic, we're so grateful to open up the conversation and learn from new perspectives with the team over at the Austin Riggs Center, who have been focusing specifically on this pressing topic. Without further ado, I am excited to introduce today's presenter from the Austin Riggs Center online IOP. Our first presenter is Dr. Erin Seery, a psychiatrist in the online intensive outpatient program for college students and emerging adults in Massachusetts at the Austin Riggs Center. Dr. Seery is committed to understanding patients across the lifespan and the unique challenges at particular developmental time points. She completed a general psychiatry residency and a geriatric psychiatry fellowship at the Medical University of South Carolina, and then pursued an advanced psychoanalytic fellowship at the Austin Riggs Center residential program, where she worked with clients in intensive psychodynamic individual psychotherapy, group and family therapy modalities, and in concert with psychiatric prescribing. She then joined the faculty at the Medical University of South Carolina, where she serves as the Associate Program Director and Associate Psychotherapy Director of the General Psychiatry Residency Program. She has received numerous awards for her teaching of psychiatry trainees. She's also involved in advocacy, recently named a trustee with the American Academy of Psychodynamic Psychiatry and Psychoanalysis, and will be the incoming president of the South Carolina Psychiatric Association. Also joining us today is Dr. Seth Pitman, the Associate Director of the Online Intensive Outpatient Program for college students and emerging adults in Massachusetts at the Austin Riggs Center. In addition to providing individual therapy and leading groups, Dr. Pitman designed and manages the IOP's Measurement-Based Care Initiative, an evidence-based practice of using systemic and routine assessment to inform treatment decisions and engage patients in their care. Dr. Pitman is passionate about integrating clinical research and practice to improve treatment outcomes and foster communication within the field of mental health care. He is committed to translating what we know works best for patients to policymakers and organizations that have a hand in guiding resources and helping improve access to quality care for all, including those from economically, racially, and gender diverse backgrounds. So without further ado, I am going to be turning our presentation over at this point to Dr. Seery and Dr. Pitman.
Just wanted to say, so I'm going to start off. I'm so glad, and I think I speak for Seth to be a participant in this presentation today and the continued discussion about unpacking loneliness. I really enjoyed Dr. Katie Lewis's presentation last week on the research perspectives on loneliness and the kind of data that's been gathered by the Austin Riggs residential program. I hope you all got a chance to attend that talk. If not, kind of watching it back later. I think just the sheer number of people who have registered for this talk and are attending today just really highlights just how important kind of this topic is and how we struggle, I think, as clinicians with addressing this with our patients. It's a human experience, but I think often working with really lonely people, it's a lonely experience too as a clinician to be with and wonder how we can be helpful to our patients. I'm not sure if anyone else is hearing any feedback, or is it just me? Okay. So I just wanted to kind of highlight that So it can be very, very lonely ourselves to work with patients and kind of figure out how to be helpful to them as they translate the work in one-to-one treatment with kind of taking steps out into their lives. So the plan for today will be for Seth and myself to be talking about our clinical ideas and conceptions about loneliness, and then move on to talking about kind of strategies and approaches that kind of we consider kind of within our work at the Austin Riggs Online IOP. Seth and I, as was mentioned already, are graduates of the psychoanalytic fellowship program at the Austin Riggs Center, which is the kind of residential setting where I think an important part of how we see improvement in our patients is in the development of a community and in patients taking charge of their lives and developing social connections from kind of examined living and kind of building those connections at multiple different levels. So, and we can share kind of later kind of what we took from the residential setting into the IOP, which is a all virtual program. I wanted to kind of begin by talking about, I think clinically to address loneliness, it really starts with your own frame of reference or the lens that you're using to really think about what loneliness is and what it means. Kind of what does it mean for the individual person? I thought that Dr. Lewis's presentation last week was really helpful in framing like the research definition of loneliness, which she described as the discrepancy between the desired level of social connection and then what has been achieved. So kind of that gap between what you want and what you hope for yourself, and just all the feelings that are loaded within that, feelings about yourself and your capabilities, and whether you're going to be able to make those connections that you want. So as a psychiatrist, it becomes kind of complicated because I think modern psychiatry often kind of with a more biomedical revolution has left us to be maybe sometimes more reductionistic, where we kind of think about different symptoms as characteristic of a disorder. And then it leaves us with treatments that are kind of more concrete, so medications or in a biomedical interventions. And I think we lose something in that kind of description, that loneliness is more than that. Although I think, as we mentioned earlier, patients for who have history of depression that is associated with withdrawal, social isolation, and those patients may feel that differently, the loneliness in the context of being depressed, or patients with psychosis who also have struggle with connection and social isolation, patients who've experienced generalized anxiety or trauma or panic. Social connections can be fraught with fear about what the other person will bring, or catastrophic thinking about what the meaning of the interaction is, or that they'll be like this forever. So I think really expanding our thoughts on kind of what loneliness is beyond reductionistic approaches, and then really having an individualized attention to that can be really helpful for patients. I read the New York Times article that we shared around prior to this talk, and it was really helpful. I think, is there, I forget what the specific name of it was, but it's around loneliness epidemic. And I really liked a couple of their definitions of loneliness that I thought would be helpful in framing how we then approach patients who experience this. And they described it as a mix of sadness, anxiety, fear, and heartache. And those are like very powerful emotions, especially all clustered together. It makes me think about when it comes to anxiety, fear, and heartache, maybe an anxiety or fear that the reason why your connections are different than what you would want is because of some kind of fatal flaw that you have, or some way that you cannot interact, and also potentially a fear that the way that you feel right now, your level of connections to other people, it's going to span into the future, and that's all you can expect for yourself. And so it's very loaded for people to experience this, and especially the meanings that they associate with it. The other definition that I found really helpful for me is that loneliness is perhaps a biological signal, like hunger, that motivates a person to connect with other people. And I like this definition because it takes the kind of pathology out of it and makes it kind of a human experience, and also one that could be expectable or actually drives connection. However, what's complicated about that is hunger. As long as you're not suffering from food insecurity, you have a bevy of options to fulfill that specific biological need. You can choose all different styles of food. You can deliver it and have it come right to your home without interacting with anybody. And loneliness is something different because it's a person, when you're seeking out connection, those connections also have to choose you too. And you might find that what is on the buffet of options are limited to what you might desire, or you might leave unfulfilled or only partially fulfilled by those connections. And so it can be equally painful, but I like the idea of thinking about it in this particular way to kind of destigmatize it, to humanize the feeling, and to kind of recognize that the push is to try to find connection. And that those are all things that are just loaded into one particular person, and so it's very textured and complex. And I think in order to approach how you would treat a patient suffering from this is really understanding their particular feelings around the experience. On top of that, we kind of at the RIGS program work with emerging adulthood, which is a time of significant change and uncertainty and questions about yourself and trying to who am I in the world. And then on top of that, we're dealing with the kind of aftermath of the COVID pandemic, which we're still in, but in a different way than we were 4 years ago. And in the context of the pandemic in 2020, mid 2020, I recall with fear that connection to other people actually felt kind of dangerous to me, watching what was going on in New York and watching old movies where people were all gathered together for a party. And I was thinking to myself, they're way too close. And so I can only imagine what it's like for our patients who are coming of age at that time, where connection is fraught in all kinds of different ways, and also because it could be dangerous physically. So I think that all these things come together with the lens that we use, whether we're working in psychotherapy or medication kind of management, to try to really disentangle what the symptoms are in order to best address it. So it could mean prescribing medication to be helpful to somebody, but also having an idea about the value that the loneliness serves, what it pushes you to, and then how to make sense of those kind of challenges in making those connections. So with that, I'll go ahead and pass it off to Dr. Pitman to speak for a little bit.
Thanks, Erin. And thank you, Amanda and Dorm and everyone so much for inviting us. I'm really very pleased to be here. There's a lot of people in the audience, so I'm a little intimidated too, but that's all good. It's a big community and we're talking about loneliness. And so that's right where we want to be. So thank you very much. So I thought I would just sort of begin by orienting the conversation, at least my portion of it, with a quote from Erik Erikson, who you may know is a German psychoanalyst who emigrated to the US, had to bridge a big gap in his life from where he was born to where he ended up, and who was really one of the first psychoanalysts to bring psychoanalytic ideas to and principles into the psychosocial realm. He's also the person for whom at RIGS, our Institute for the Education, Research, and Advocacy is named. So he's an important figure for us. And he described the transition from adolescence to adulthood, this emerging adult space, in the following way. So this is a quote. Like a trapeze artist, the young person in the middle of vigorous motion must let go of his safe hold on childhood and reach out for a firm grasp on adulthood, depending for a breathless interval on a relatedness between the past and the future, and on the reliability of those he must let go of, and those who will receive him. And later he says, he must also, this is the emerging adult patient, detect some meaningful resemblance between what he has come to see in himself and what his sharpened awareness tells him others judge and expect him to be. So I wanted to start there because I think this quote really helpfully illustrates the sense of vulnerability and uncertainty that many, if not all, emerging adults experience, even in the course of typical or normal development. And then when we pair these normal stressors with early developmental experiences in which they may not have felt adequately held or cared for by their social surround, whether this be parents or families or communities, that this can really manifest as intense loneliness, intense social isolation, And then, of course, all of the other symptoms and difficulties that we tend to face in our clinical work. Last week, as Dr. Lewis, I think, very helpfully described in her presentation, loneliness, and also Erin alluded to just now, loneliness is not merely the absence of social connection. It's a really complex and multifaceted experience. And a person's perception of the quality of their connections is often as significant, if not more so, than the number of connections they may actually have. And so because of this, loneliness is a very rich area for exploration, especially in depth-oriented treatments like psychoanalysis and psychodynamic therapy, which is the foundation of our treatment approach at Briggs. Well, of course, not exclusively those types of therapies, but in treatments where we try to get a little bit deeper and try to understand a little bit more, there's so much to explore and to learn about. And as Erin and Katie both also said, it's very important to notice that loneliness is a deeply human experience. And it's not something that we just want to treat away entirely. I think instead our goal as clinicians and therapists is to understand its nuances and help patients uncover aspects of their loneliness that may be outside of awareness so that they can try out new approaches or have greater access to capacities that already exist within themselves, but that they previously felt were off limits or out of reach. So when working with young adults struggling with loneliness, I think it's important to balance humility with confidence. So on the one hand, it's important that we all recognize that loneliness is a societal issue, often driven by forces that are well outside our control, and also rooted in experiences that are in the past and have already come and gone. But on the other hand, I think it's so important that we understand the significance our patients place on their relationship with us. In many ways, I think we are the receivers that Erickson described. We're there to sort of help catch young adults in their transition to adulthood as they search for meaning and belonging. And taking seriously the hope and trust patients place in us, even in the first moments of the first meeting, and there's research to support this, within seconds, patients make judgments about whether their provider is trustworthy and available to them, really within seconds. So much hope and trust gets put in those few moments. It can be so powerful to really own that, I think, as therapists and as clinicians. By focusing on understanding our patients as people and how they perceive their lack of meaningful connections, we can help them explore and understand how their social needs are not, or maybe even in some cases are being met. So put another way, I think of our therapeutic task as understanding what stands in the way of meaningful connection, and particularly what our patients are doing, either consciously or unconsciously, to contribute to this disconnection. Not to place blame, but to understand. Also, Amanda alluded to briefly last week, some of the research that she and the dorm are collecting in their work, and this echoes findings that we are also finding in our measurement-based care initiative at Riggs. So we found that loneliness correlates very strongly with all kinds of symptoms, like probably all of the symptoms: depression, anxiety, personality issues, interpersonal difficulties, even suicide risk, substance use. And interestingly, we also have found that patients who report higher levels of loneliness at intake in our IOP also tend to report poor quality therapeutic alliances, which is a very meaningful finding. At the same time, the research we've been doing shows that a strong sense of social connection for both therapists and patients during Zoom virtual therapy is a key factor in building robust alliances. And so one of the tasks that we've had is how do we build connection across the virtual medium? And of course, we're all spending so much more time online on Zoom than ever before. And so this is a really important treatment target and thing to understand. And I want to talk a little bit more about this question about alliances and, good or bad alliances. So of course, as clinicians, we're not only striving to foster strong alliances. That is, of course, desirable and important. But I think it's equally important that we not lose confidence when that seems not to be happening. Instead, I think the issue can become recognizing when and why our alliances are faltering and how this might link up with or relate to the loneliness our patients experience outside of treatment and also with us. So poor alliances or not great alliances, while being very challenging and really need addressing, also offer valuable opportunities for exploration and allow us to build roadmaps for how to deepen and improve our patients' relationships, with our relationships with them and theirs with the people in their lives. And so to that end, I think it's useful to think of alliance not only as about being, nice and positive and getting along well, all important, but it's about joining our patients around a shared task that's rooted in their lived experience, including their experiences of loneliness, about what needs to be noticed, what needs to be explored, and what needs to be understood about that loneliness. And I think this approach can allow us to carefully target what might be impeding meaningful connections and also explore the roots of those interpersonal dynamics and perceptions. I thought I would take just a few minutes to offer kind of a clinical vignette. It's not going to be very in-depth, but it'll illustrate hopefully some of the principles that I've been speaking about. So I was working with a young man in his 20s in the IOP, very intelligent, very likable, but really struggling to live up to his potential and feeling increasingly hopeless as a result. And he didn't really report feeling lonely, actually, but he did seem to fit the profile that Dr. Lewis spoke about last week, this sort of existential loneliness. Person who is somewhat emotionally avoidant, may have an avoidant attachment style, and who feels that their experience is so unique or so different that other people really can't understand it at all. This was really the flavor of my work with him. When he was a child, he was struggling a lot in school, and he hid that his struggles. He went to great lengths to hide his difficulties. This is sort of a family culture issue. This is a family that didn't reach out for help when they needed it. And he took this into the classroom. And the more he concealed his difficulties, the less his parents and teachers could understand what was wrong, which in turn, of course, deepened his sense of isolation. And he came to believe he was broken and toxic and deficient. And then as an adult, he continued this pattern. When he was struggling, he wouldn't communicate his problems to others, and instead he tried to hide them. And this ultimately led people to feel very frustrated with him, very disappointed in him, especially when they were trying to rely on him for important things. When he began his work in the IOP, he complained a lot about how groups weren't helping him. He felt like he wasn't connected to the other members and that the conversations were too superficial to be useful. He also seemed to think our connection, our alliance was positive, but I, on the other hand, was sort of struggling to feel connected with him. I felt like our work was pretty superficial, and sometimes I frankly felt confused by what he was talking about. And so over time in our therapy sessions, I gained the confidence, or I found the opportunities to kind of confront him with this experience that I was having when he would complain about groups or people in his life and about himself. I told him as compassionately as I could that when he emphasized how toxic and broken or different he was, I felt actually very different. I felt very distant from him, as though he were creating a lot of space between us. But I told him that when he broke through that a little bit in the moments when he was a little more honest and vulnerable, talked about sadness or hopelessness or even his suicidal thoughts, I suddenly felt like I could relate to him and that I understood him and that I felt drawn into wanting to lean in and support him emotionally. And so there's a bit of translation that had to happen there. So try to interpret that, it's not that he was a toxic person who people would abandon if they really knew him, but actually it was the interpersonal strategies he was using, pushing people away and distancing himself, that was a big part of what was leading him to feel alone and misunderstood. And when he was a kid, of course, he didn't have a lot of opportunities to, or he didn't have a lot of strategies to cope with shame or disappointment or judgment. But as an adult, things are different. And what is he really afraid of now? Like, what does he stand to lose by being a little bit more honest with people? And so I think that work involves sort of 3 steps. First, identifying these defenses that he used to avoid connection and the interpersonal consequences that followed. Second, exploring the fears and painful emotions that motivated those defenses, especially in the first place. And then finally, trying to identify and work with him around new strategies and encouraging him to test out new approaches in the IOP, but also elsewhere in his life, to building connections and to trying to strengthen some of those bridges between himself and others. So that's my portion of the conversation. We're going to segue a little bit to talking about solutions and strategies. And to that end, I will quickly outline just what our program looks like in the RIGS IOP to give you a sense of how we do this work. So our IOP consists of 3 hours of groups, 3 days a week. They're the same 3 groups. The first group is a process group, which we call Resilience Through Relationships. The second group is a yoga, mindfulness, and meditation group, which is sort of a body-based movement group to help break up the Zoom fatigue and get people into their bodies. And then the third group is a coping skills group that we call Skills Within Stories. We also offer twice weekly psychodynamic psychotherapy We offer psychopharmacology as needed with a psychodynamic focus. And so this is, Erin can say more about this, but it can be as little as monthly check-ins or it can be weekly meetings. It depends on the case. We also offer family therapy as needed. And we hold 3 times weekly multidisciplinary team meetings, including a case conference for every patient at week 6, which we invite referring clinicians to attend and participate in. And then patient visits the team as needed, including at the beginning of their treatment when they first enter. And this first point of contact that we have with them is important and links up with the questions about loneliness and belonging because, let me take a step back. So we operate using a psychodynamic team model. And so we meet together as a team and then we invite patients in to meet the team. And when we do that, we're really, I think, trying to claim them as members of the community, members of our team, working with them and try to really emphasize that their voices, their perspectives, and their goals are so important. In fact, they're guiding the work that we're doing with them. More generally about our team, psychodynamic teamwork, there's a few core principles that I want to outline, and then I'll hand things over to Erin. So we think of symptoms, including loneliness, as meaningful expressions of some developmental conflict that has occurred. We also trust that what a person can't bear or understand is often communicated through behaviors and behavioral relationships, sort of like the one I outlined in my clinical vignette, and including with us as treaters. And we also think that individual suffering carries group influence and significance, meaning when one person suffers in a group, everyone is taking part in that suffering to some extent, whether that suffering is being offloaded onto that person or whether that person's suffering is causing other people to suffer or to feel anxiety or to mobilize different kinds of defenses or behaviors. The one is always part of a whole. And so our team is always trying to hold tensions and anxieties that arise over the course of treatment, balancing, clinical management with interpretation. And so we're trying to take the pieces that we see from therapy and from psychopharm and from group experiences, trying to integrate all of those different sources of information into a coherent whole that we try to really communicate back to the patient during the case conference and then the work that follows.
I did want to kind of just share that I'm watching the chat too and the questions that are coming up. And I think, I think we do as individual clinicians have to recognize when we're not enough for the patients in order to figure out what else is it that they need. And that's where I think intensive outpatient levels of care come in and partial hospitalization programs and skills building and all those kinds of things to help add in addition. Because for patients who are coming to us with complex histories and very rigid personality structures or very particular ways that they're stuck in their own life, the way they think about themselves or stuck in relationships, it really does take kind of the addition of other levels of care to really break through that. So not just the talking about what these are one-to-one, but then how do you translate that into groups? And there are different ways to do that, different theoretical orientations and models, and ours is really honoring the meaning of symptoms, and then within the process group, the kind of chance to connect with other people, test out what happens with a moderator to kind of be there as the discussions are happening, and then to reflect on those in the individual therapy that's intensive in a way. And then, for us staff as well in our program, I feel very connected to the other staff members. We meet several times a week. We share experiences. We have open time to share kind of all of our reflections and hold those together. And I think that kind of we model something for our patients about the value of that. It's such a challenging topic. Someone wrote in there that we need to have a course. I think that's probably true, or kind of a university major in it, because it's a really complex topic.
Maybe I'll just wrap up by saying just a quick word about some of the ways that we approach groups, the process group and the coping skills group in particular. So in relation to belonging and loneliness. So our process group we call resilience through relationships, because we really, believe, I'm sure as many, if not all of you do, that, resilience isn't just like you have it or you don't. It's an internal thing. Of course, we have capacities. Some are more resilient than others, but it's through our relationships with each other through the support that we're able to both receive and give, that we feel like we can get up day after day and do the difficult things that all of us are trying to do in our lives. And so we see our process group as sort of like a here and now group that gives patients a chance to explore all kinds of experiences, including feelings of loneliness and disconnection in real time. And so we try to comment on moments when a patient, for instance, is speaking about something challenging and no one responds. And why is no one responding? And also, what's it feel like for this person to speak and not be responded to? And then also solicit feedback from the people who are not responding, like not only why are you not for yourself, but is there a way that this person who's speaking is communicating that's shutting down the conversation? And this is frank and can be challenging, but is really valuable interpersonal learning that if patients can, I think, optimally feel supported enough to hear some of that sometimes challenging feedback, they can bring that elsewhere in their lives and they can use that learning. And so it's really about engaging the whole group as a whole to help patients identify and address obstacles that are preventing them from forming these meaningful connections. And then in the coping skills group, we call Skills Within Stories. This is a group that I lead. It's a mindfulness-based group loosely, but it's sort of like mindfulness in the context of understanding one's entire life, not all at once, but one's story and how one arrives at the judgments and thoughts and reactions that we're faced with moment to moment. That's the sort of mindfulness piece. And so we really try to develop skills that aren't just boilerplate and top down and suggestions like try this, try this, try this, but are actually kind of unique to the patient's story and self-understanding and what really works for them. And I think this goes back to what Erickson said in that quotation about how young adults are looking for resemblances between their early experiences and their current experiences and current relationships. So we try to unpack where the loneliness originated and then how they are interpreting present day events in relation to what came before rather than what might be happening in the moment. So if we can slow the process down a little bit and be a little bit more mindful, help patients be a little bit more mindful of their experience when lonely feelings arise or lonely thoughts are activated, what is actually happening here? Where is this coming from? And is it possible to see things in a little bit more of a complex way right now? And then from there, are there opportunities to, think of new strategies and then solicit at this point support from other group members? Have you felt like this before? Can you relate to this? If you have felt this way, what have you done? What's worked? What's not? And then it becomes a really collaborative community building kind of experience around, hey, we're all struggling here. We all, many of us are feeling lonely. Like, not only can we talk about those experiences, but can we help each other think about them? And we try to put that really into the patient's hands and not try to hold all of that as the clinicians or as the group consultants.
Thanks so much for delving into, exploring not only the topic of loneliness and sort of conceptualizing, what does this really profound word actually mean when people are saying, I feel lonely? What does that actually mean? And then also thinking about some of the solutions and the treatment and the way that we address loneliness in a treatment center, in a treatment community. I so often hear that loneliness being described as a symptom of various diagnoses, right? Like somebody will come into treatment and they'll say, I have depression, or I have anxiety, or I have trauma, or I struggle with substance use. And then you say, okay, tell me more about that. What does that mean for you, right? And at some point in time, usually by like the third sentence, you'll start hearing them talking about loneliness in some way, shape, or form, feeling disconnected, feeling isolated. And I feel like as a treatment field, so often, the prevailing thought is, okay, so if we treat the depression, if we treat the anxiety, if we treat the trauma, if we treat the substance use, like treat those issues, then the loneliness will get better, right?
Yeah.
Like we have to treat the illness, which isn't untrue necessarily. And in many cases that is very effective, right? Like clients participate in intensive DBT or EMDR, trauma-focused therapy, ACT, and they feel symptom relief. And as they're feeling symptom relief, they start connecting more. And I think there's another side of the equation too, because we get so many clients, as I'm sure you do, who could probably run a DBT group very effectively, right? They know all the skills, or they just don't want to do that type of treatment, right? There's like a resistance. I've done it so much, or I'm not interested in that. And what our research is showing is that the opposite is also true. You can actually treat the loneliness, and by treating the loneliness, the symptoms of the depression, the anxiety, the substance use, the trauma will improve. So it's great news for so many reasons. It gives us more tools in our toolbox, right? To work with and how we think about treating clients. But when I look at our research, we're looking at some of the community or connection metrics that we're looking at are things like ability to participate, friendship, rejection, self-efficacy. And what we're finding is that there is significant correlations between things like friendship, rejection, self-efficacy with improvements in anxiety, depression, and overall well-being. So if we get a client that says, nope, DBT, not for me, not doing it, okay. How would you feel about joining the botany club at 4 o'clock instead of DBT group? How would you feel about joining the social justice and advocacy club? How would you feel about joining this social activity or this yoga group or this mindfulness group? Like there's groups that are much more social, like conventionally social in nature. How would you feel about joining the group that volunteers twice a week together? And for many clients, there's less resistance to doing that, to joining a group where we go play pickleball. And they start making some connections. They start having some corrective emotional experiences, not only having more quantity of connections, but also quality in their connections. And we start seeing symptoms of the presenting problem dissipate. And then we start seeing them be more open to DBT, CBT, et cetera. So I just think it's an interesting way to think about how we approach treatment, and to always remember that there is an and, right? Like we can address a symptom, or we can address issues from multiple different perspectives. And that's okay, right? There's power in evidence-based treatment, and there's also a tremendous amount of power in experiencing joy and laughter with peers while playing pickleball with them too. Like both things are true.
Yeah, I really think it's important to attend to the individual and what will be helpful for them, and what are the solutions as opposed to what they must do. It's never really good with a young adult to tell them what to do.
Correct. I'm also going through the chat right now and seeing people commenting on recreational groups, forming friendships, which we as therapists can't necessarily replicate or replace. Yes, it's yeah, there's certainly a power in those connections as well. There was a question that came in, and I'll throw it out to both you, Erin, and Seth. Do any of your practices offer these types of social skills groups or practices for individuals who are on the spectrum?
Some of our patients do carry ASD diagnoses, or we suspect that when we meet them and engage with them. I think our approach is kind of similar within the group. And then as far as it is challenged with people who are more rigidly set in their social issues and trying to kind of connect in that ways. But we've had success with patients who are on the spectrum and using the groups and using the therapy too to kind of understand the reactions of the groups. And sometimes getting a diagnosis is helpful for these patients to understand something about that particular kind of struggle that they have. I know that some colleges do this as well. Clemson, kind of close to where I am, has a particular track for patients who are on the spectrum to help them settle into college and kind of have a community within themselves.
There's also, this is a really interesting question as well that that came in, and I've gotten this question before. I'm curious your all's thoughts on this. Amy Nash said that she has heard a definition of loneliness as a discrepancy between a desired connection and the actual connection. But she wonders if a patient feels content or says they're content in their solitude, is there a place for a therapist to explore the lack of connection and how? And this is just fascinating because I know, and I'm sure you all have seen this too, that for many clients, when the world went into lockdown world, there was like a sense of relief, right? Like they did feel relief and content that like they could socially isolate in their space. So this is a great question from like a therapeutic standpoint. Somebody says, I'm really content in my solitude.
I mean, you know, it's an impossible question to answer sufficiently because it's so individualized. But my first question would be, well, okay, so why are you in treatment? If you're really that content and it's really working for you, then what are we here to work on? And I, you know, so I wouldn't. My first response would not be to challenge that or doubt the reality of it, but I would want to know what they do need to work on, or what they feel like they do want to work on. And then there are those cases, of course, which one of my supervisors from graduate school called referral by earlobe. Like the patient doesn't want to go to therapy, but a spouse or a parent or a significant other needs them to go because, let's say, you know, this person's just too content in their solitude and there are relationship issues, relationship needs that are not being met. And so in that case, you know, you want to get the context of why the person has been, you know, is showing up in your office. You know, in the vignette that I shared earlier, you know, this is a person who I worked with who didn't really talk about being lonely all that much. He was pretty dismissive when I suggested that he might feel lonely, or that when there was a relationship breakdown that he might feel sad about that. Even as I'm sitting there in the room feeling sad, and I could say, you know, an easy way out for me would be to say, oh, maybe this person's autistic and they just don't care or something. But, you know, first of all, that's not how I think about autism. But you know, to just dismiss that as either like a pathology or take them at their face value, I think both approaches are sort of missing. There is distress here enough for the person to be here, and is there an interpersonal or relational aspect about this that this person might not be aware of? And so for me, you know, this is where, as an analyst and a psychodynamic clinician, I make use of my countertransfer. It's like, what do I feel? What am I feeling in this room with this person? Do I feel lonely? Do I feel like I'm being pushed away? Do I feel frustrated? And I try to use those emotional clues as ways to try to think more complexly about a problem that may not be identified by the patient as a problem in and of itself.
I was just thinking that this kind of question would come through with most likely a parent calling our program coordinator around a patient who's kind of maybe in a space of a failure to launch. And in those situations, sometimes we do family work within our program, which is to try to find where the conflict is. Because if it's not within the patient, it might be within taking steps towards adulthood that are necessary. And to what extent is it helpful to be uncomfortable, or is it not helpful to be content with lack of connection if other things are suffering or your development is suffering? And so kind of often that's where the rub is, I think, is that other people recognize the problem when the patient themselves feels fine and content, but with a very small world in front of them.
Right.
I guess I just wanted to say one more thing. I totally agree with what Erin just said. You know, I think that so there's a psychotherapy researcher who's incredible, whose name is Bruce Wampold, and he talks a lot about how like humans are like the most social animal. Like that's actually how we are designed, is to be social, to work on problems together, to address challenges as a collective. And when we try to go be too individualized, that's not actually how we're built. And so I'm always, I'm always thinking that we're always thinking, there has to be an interpersonal social aspect to any aspect of distress that someone is experiencing. There's nothing that exists in a silo. And so we try to just bring that in as we find opportunities to do so.
Yeah, agree. Can you speak more about addressing systemic, institutional, or societal barriers to connection, such as ableist policies and discrimination that prevent genuine connection? And as Dr. Seery mentioned, can make physical but also emotional connection dangerous. When other folks put someone in danger and also show in their actions that they do not care about inclusion or safety of others, this can be harder to resolve than individual challenges or internal LOC barriers to connections. Yeah.
I do think it starts with our own awareness of our biases, or what we don't, we're not aware of the challenges of other patients. So I think being open to that experience of a patient who experiences life from a perspective that the world is not made for them, it is a good first place to start. And then I do think that is one great thing about kind of virtual kind of programs, is that it removes some of the barriers to like traveling physically to get to places, although, as we know, kind of creates its own kind of separate problems in translating from kind of in your home to outward. But those are kind of my thoughts based on that question. It's hard to be in a place where you already have so much disadvantage and inherent beliefs about how people are going to kind of interact with you. And so I think it's an added challenge where people are starting even behind the starting line. Just being a person that recognizes those things, I think, can be very helpful to patients, even if we can't fundamentally change all of society.
Mm-hmm.
Yeah, I mean, I would think I have like 3 thoughts that maybe are related. So one, I think, is just trying to chip away at the barriers to access to care, and to, really make a good faith effort to bring good treatment to people who, for systemic reasons, may not have access to it. That's one. Two is to like acknowledge and recognize when that's occurring within the treatment. So our team is largely white, and when we have patients who are not white, we don't want to pretend that that's not happening. We hold it in mind. We'll try to address it. We'll try to ask about it. We'll just be aware that it's a fact of the situation, and that it's one that we're going to try to attend to in some capacity. And then two, I think when we talk about these systemic issues, I think that this can be one way as clinicians we can think about this is, as a therapist or a clinician or psychiatrist, we are authority figures. We represent authority to our patients, the authority around treatment or mental health or whatever the authority that they're imbuing with us. They're seeing us as representing something about authority, which automatically links up with something about society. And for folks who have had really problematic experiences within a society that they feel for one reason or another was not made for them, they'll bring that to treatment. And it's up to us to listen for that and to try to find moments when that might get expressed, and to not shy away from owning, hey, I'm a white man authority figure, and you're going to have feelings about that. And I'm not going to pretend like I'm the good guy who is, somehow outside the system. We're all part of the system. So can we find those opportunities to just, honestly look at those issues?
Right. And that in and of itself provides a corrective emotional experience. Just that conversation and you having that conversation,
Right.
is powerful in and of itself. Hold on, I'm scrolling back up because there was a question that came in the Q&A and the chat. Okay. Is there a way to determine whether a sense of loneliness is any greater now than it was when Erickson was writing about identity formation? Holding the pandemic aside, is it likely they were having the same concerns, but it was not something that was a part of the popular dialogue. Oh,
I do know that that's partially grew where the concept of emerging adulthood has grown from, is this idea that there used to be one more solid path into adulthood, kind of school, then marriage, then whatever it was. And so people had those built-in connections, and now there's more kind of a moratorium in a way, which I think allows time for exploration, but also for a lot of people who don't know what to do without structure, kind of leads to this. So I don't know specifically what's been researched about it, but I would imagine that there are differences from Erickson's time, although a lot of similarities as well.
Yeah, I mean, I think I think about it. I think about it in two ways. One is that there is more freedom of choice now, probably than there was then, and that can bring up existential issues around where do I fit in? What am I meant to do here? It's not quite as clear cut. That I think might exacerbate experiences like loneliness. But let's not forget that also like World War II was happening and all of these huge major disruptions and losses and the Holocaust and this, that, and the other thing. Of course, many of these atrocities continue, but like that was what was happening then, and I think that was probably a pretty terrifying and lonely time. And so it's I don't think it's an either or. I think things are different, but I wouldn't say it's more or less. That would be my hunch. It's probably not more or less. It's just different.
yeah. Yep. How does loneliness relate to acute anxiety and social anxiety? And what modalities or treatments have you found specifically work for this young adult population?
I know Dr. Lewis last week spoke about in the research on loneliness, particular factors within patients. She mentioned maladaptive social cognitions, bias cognitions, perceptions, and then concerns about social threats. And so I wonder, kind of in a person who is highly anxious, that there are certain cognitions about the social interaction which might get in the way of making those connections, or have someone come away from an interaction really self-critical and judgmental. And so I do think one of the starting places for that is within like a psychotherapy, to kind of understand what has happened. Sometimes for some people that the noise is so loud that medications might be something that could help minimize and help kind of the person self-reflect. And then kind of the chance to have within kind of a more intensive outpatient program or a group or something, kind of to have experiences that negate the kind of the anxiety response, so that someone can kind of realize that their concern for social threat is so higher than what it might be for the interaction that they have.
I don't know that I have much to offer. I mean, I guess I think that I'm trying to find the question. It was social anxiety and loneliness. I mean, I would think that there's probably a vicious cycle at play, that the more anxious and socially anxious someone feels, the more lonely they feel, and then vice versa. And that, and I don't think any one therapy is the one that's going to target it most effectively. I think all therapies that are legitimate are going to have different approaches that are, stand a chance of being helpful. Psychodynamic psychotherapy, interpersonal therapy, schema therapy, DBT. These are all tools that we can utilize to try to work at the problem. I think the biggest point though is, who is the person? Who is the patient as a person? What are their experiences? What has come before? Where are they trying to get to? And using that as a basis to implement any of the strategies or treatments or tools that we have available to us.
I am mindful of the time because I know that a lot of people have sessions and commitments to get to following this presentation. So I know that there's some more questions that we didn't get to. It seems like we're going to probably need a part 3, 4, 5, and 6. This is such an important topic, but thank you. Thank you again to Katie Lewis for joining us for part 1, and to Seth Pitman and Erin Seery for being here for part 2. As I said, please keep an eye on your inboxes. You will be getting an email that gives directions for how to complete the evaluations, so that you can get credits for everything. If you did not get the slides from the original presentation and still want them, let us know. If you're having any difficulties downloading for CE credits, please let us know. Yeah, if there's more of a desire to have follow-up presentations or workshops on this topic also, or any other topics, let us know as well. We love bringing together different collaborators to speak on these really important topics. So thank you all so much for being here. And we will see you all soon.
Thanks so much, and thanks for all the great questions.
Yeah, thanks.